So in the next few minutes, I will give you some impression, and I hope also to give you some motivation about cellular therapies, because this is really something which will change our life. And as you well know, cellular therapy is not affecting only hematology and oncology, but also other faculty members of medicine, like we have cellular therapies in cardiology, we have cellular therapies in many disciplines in medicine. So I just want to show you some past issues, some present issues, and what we are going to have for the future, perhaps. So all started actually in the 50s, and here you can see one of the papers in Science, which has been published by Jacobsen, which showed that if you are shielding mice in the spleen, you can give them radiation injuries and they still recover. At that time, to have cellular therapy was an unusual way to think, or a cellular recovery, because they were thinking only on plasma factors. And a few years later, actually, they demonstrated that by giving spleen cells to a mouse which was irradiated, she could recover. And they showed also that the sex of the mouse was from the donor and not from the recipient. So this was the first proof that you can transport or you can transplant a cell to another individuum, which was quite unusual. You know, pharmacology is now hundreds of years old, but this is just a new era which is starting in the 50s, and which was also the inspiration for Don Thomas. But the first, actually, transplantation was not cellular therapy, it was an organ. And you can see Joseph Murray in 1954, which made a kidney transplant in these twins. So this is not a pure chance that these are twins and they were successful, because at that time it was not known that we have tissue antigens. And so he did this just by chance in these twins. Now, Don Thomas, in 1957, the general manager alluded that we have now 60 years of stem cell transplantation. He used bone marrow, not here the modern way to collect these stem cells, and he gave it to 6 patients which had either radiation injuries or also leukemia, which was not responding to anything. All 6 died, but he was the first one which showed that these cells are remaining, or they changed the blood group. So that was the first evidence that you can substitute cells of the hematological system and of the immune system. Now, the experience was not very good at that time. 200 patients have been transplanted. And you can see here that only 3 survived. So this was terrible because the patients either died of graft failure. That means that the stem cells didn't home, or they died of a reaction from the stem cells to the recipient. So most of them actually died from graft failure. So that means that they didn't have leukocytes, platelets, and red cells then, and that was the cause of that. So Don Thomas was very perseverating, and he went back to the lab, and actually he then started on looking at why these were unsuccessful. What was the determination for graft rejection and for graft versus host disease? And he found in littermates, in dogs, that only the littermates which were actually of the same bred, they were successful and grafted. and they had also a take. And he then developed the idea of matching, and later on HLA matching was also used to select the donors, and then it turned out to be successful. And you can see it here today from 1957, how this developed. So in the first 20 years, there was an input of many scientists, not only hematologists, but also immunologists, many disciplines in medicine then contributed to this work. And you can see that in 2012, we reached worldwide 1 million of transplant. Of those are 600,000 autologous. That means they have the stem cells from the patient's own stem cells, and about 400,000 have the allogeneic stem cells. Now today, many societies are involved in stem cell transplantation, and therefore the World Health Organization asked us to put this all under one umbrella and make a federation which we call WBMT. And we also were able to help continents like Latin America. We founded the LA-BMT, and we had the first meeting just 3 days ago. We founded the African BMT, and now we are collecting as a first step the activities of all these transplant centers in the world. And you can see that in 2013, we had 70,000 transplants per year. So this is in 4 continents, 78 countries, 1,557 teams. And you can see that about half are autologous and half are allogeneic now. This changed a lot in the last years. We have 48% of family and 52% of unrelated transplants. And if you're looking at the teams, you can see here that we have teams all over the world. And you can see that you have still some countries which are not transplanting and don't have teams. But in the meantime, by making our workshops, they started to make transplants also in Mongolia. They started to make transplants in the Philippines, and also we have in Nigeria and in different parts. But we are still not there to have that every patient in the world has the possibility to have a transplant. And this is not correct by saying that this is a very expensive procedure. Of course it's expensive, but sometimes it's the procedures which is the more effective and it's life-saving. And if we are looking further in the drug prices, we will see that sometimes the curative treatment of a stem cell transplantation, it's even cheaper than the newest drugs which we have today. So the autologous and allogeneic stem cell transplantation are increasing from 2006 to 2013. You can see it here. The autologous are a little less than the allogeneic, but you can see that there is no plateau here. So we are still in the, we still need, we are not saturated. So still a lot of patients still need the transplant and they are not transplanted, which sometimes is the only curative treatment. The reporting centers here, you can see that there seems to be a plateau in 2013. And if you're looking at the different continents, you can see that 48% of the transplants are coming from Europe, 29% from the Americas, 20% from Southeast Asia and Western Pacific, and 3% from the East Mediterranean and Africa region. Now, you can see that here the transplant rates per 10 million inhabitants. So that means we have in Europe 379 transplants per 10 million inhabitants. In the United States and Canada, we have more. But we have regions like the Latin America, in Latin America, where we have only 63. So this is just a little piece of what we have in Europe and in the US. In the APBMT, we have 45, and in the EMRO region, 29. So if you're looking this at the chart and by the different countries, you can see that the darker areas means more than 500 per 10 million inhabitants, 500 transplants. And you can see in Europe that we have still to improve in some part of Europe and to make it possible that also these regions can reach what we will call standards for the population. So we need to have improvements. Of course, this is not only for increasing the transplant per center. This has to be a way that after certain numbers, the transplant per center is going to be too big. So it needs to have equal distribution where also the patients can choose where to have the transplants. So what are the indications? The indications for allogeneic transplants are leukemias. 72% of all transplants, allogeneic transplants had leukemias. Lymphoproliferative disorders, 13.7%. And for autologous, these are lymphoproliferative disorders, about 90%. And this means myeloma, but also lymphomas. So 90% here of all transplants in the world, in Europe, in America, 91%, in Europe, 89%, are done from lymphoproliferative disorders. There are some smaller indications like solid tumors and non-malignant disorders, but still here we have also non-malignant disorders in allogeneic, so this is increasing. We have many diseases which are not receiving their transplant now. So if we are asking, is this increasing the transplant or it's decreasing, you can see here from 2012 to 2013 in the world again, you have an increase of plus 4% in acute leukemias, in MDS, MPS. You have in chronic leukemias -3, you have plus 5% in lymphoproliferative disorders. In leukemias autologous, you have -20%. So the leukemias now are much more treated with allogeneic stem cell transplantation. Plasma cell disease is still 5% more, lymphomas 1% more, and overall we have an increase of 3% for autologous and allogeneic just in 1 year. So what happened, what is changing in allogeneic transplants? So this is the plot from 2006 and 2013. You see that the unrelated are now more frequent than the family transplants. So that means that if a patient has no donor with an unrelated donor, we can have we have now more transplant with these donors. This is a sign that the transplant is now safer, that the transplant can be done very quickly in some countries. In some other countries, not really, but we have to help them to have the donors available. So these are, again, evolution which is reflecting the results improvement of unrelated stem cell transplantation. And here you can see what happened for those who have no donors. You can see that the unrelated cord blood are decreasing, so cord blood transplantation is decreasing, while haploidentical transplants is increasing. That means that we have new technologies where you can use also siblings which are not matching to make a stem cell transplantation. Now, what happened in stem cell transplantation in the last years? You can see that there was a continuous improvement. Patients which were transplanted in 2003 had an overall survival of 40%. In 1993, they had a survival of 38%. And now we are in 2016, so we will have another improvement, and there are different reasons why we have these improvements. One of them is that we have lower GVH rates. You can see here the transplant patients from 1990s to 2000, you can see that these patients have more grade 2 GVH and less grade 3 and 4 GVH, which has a very high mortality. And especially the hepatic graft versus host disease is lower, and the gut GVH, it's not really changed. So we need to work on these numbers, and we have now almost 5 or 6 trials in Europe which are looking at this treatment of graft versus host disease. Today, these are the results from my hospital, from my department. You can see that we improved from 32% of non-relapse mortality. That means the risk to going to an allogeneic transplant went from 32% to 7% in the newest thing. So you can tell the patient we have a risk, of course, but this has been diminished quite considerably, and we still have to work despite matching, despite higher age of these patients, we are improving. Now, one thing which has been mentioned by Ian already is the accreditation, JC accreditation. You can see here the curves in a paper which we published some years ago. You can see that the centers which are either accredited or applying for accreditation have much better survival than centers transplanted in centers which are not thinking about JC accreditation. So this is about, you can see this is a 10% of survival advantage, which it's very important because we are saving lives of patients, and also it's important because we have to employ or to use the money for this expensive treatment in the best way possible. Now, worldwide, we have now more than 30 million of donors. We have about 4.5 million in Germany only. We have 40 different registries in Germany, and we have also cord blood units, and you can see the transplantations now reached, this is an older slide, more than 1,250 transplants. So one other point which I want to make is reduced intensity toxicity. We started to understand why transplant works, not only because we are giving chemotherapy, but also because of immunology is working after stem cell transplantation. You can see that we use these different conditioning regimens, like the reduced intensity conditioning or the non-myeloablative conditioning to treat older patients. And these older patients now can have a curative treatment up to the age of 75. This is a paper which we published in 2011. You can see that here we have patients from the age of 60 to 64, 65 to 69, and more than 70, and there is no statistically significant difference. So there is no reason not to treat the patients over the age of 70 with a stem cell transplant. Now, the other point is that, as I mentioned before, not everybody has a donor, not even an unrelated donor, and you can see here that in the different races in the world, you can see that this is very much depending on the provenience. African American have a very low probability to have an unrelated donor, in contrast to the European one or the white one, which have a high probability to have a donor. And this is important because we have to work on alternatives for these patients. And the alternatives today are quite interesting. These are the haploidentical, which I mentioned before, unrelated adult donors or related, and we have the umbilical cord blood transplantation. Now, I just want to show you one of these methods applied from immunology, which is quite exciting because we have a drug which is quite old, which is cyclophosphamide, and this cyclophosphamide kills only activated T cells. So the idea which the colleagues from Baltimore had is to make a transplant in patients which are not matching And these stem cell transplants and T cells are activated just after entering in the patient, and they are starting to proliferate. And these proliferative T cells are killed with cyclophosphamide. The non-alloreactive T cells, which are dormant, they are not actually killed. And this is a way how these people are starting now to make haploidentical transplants. They are not manipulating the graft as we have done until now, and we are still doing, because this is still experimental. But this is a way on how we can help people which don't have an unrelated donor. And you can see the results of this haploidentical stem cell transplant with post-cyclophosphamide, post-transplant cyclophosphamide. You can see here the survival of this, which are almost quite good. Sometimes these patients are in relapse. So you can see that we have very low incidence of GVH, grade 3 to 4, and we have still grade 2 GVH, which can be treated, and it's not usually life-threatening. So this is a new method which is coming up and which is responsible for this curve which I just showed you before. The patients with cord blood, you can see here, we have 2,500 and 2,700 transplants with cord blood in 2008, and we have stored 452,000 transplants around the world. So this is a method which is available, but has some problems. The patients have, especially for older patients or for adult patients, we have problems of enough cells. We have problems of being very long in aplasia, and this is working. But again, we will see what happens in the future in the race cord blood against haploidentical. So if you are comparing this umbilical cord, haplo, and mismatch unrelated, you will see that we have almost every patient has a donor. The graft costs are very low if you're using family members. The graft acquisition time is very fast if you have a haploidentical related. The graft failure is something they have to work in Baltimore still. And the immune reconstitution is very fast in comparison to umbilical cord, where we have a slow engraftment. Now, I just want to show you some curves where cellular therapy and stem cell transplantation is of big help. These are older patients with AML, older over the age of 60. You can see that the results, when I started in Leipzig in 1998, it was just terrible. You had a survival of 10% after 5 years, 12% after 10 years. So we looked at how to improve this. It was not a problem of putting them into remission. The problem was that they are relapsing, and you cannot give these elderly patients actually a lot of chemotherapy. And we looked at stem cell transplantation against chemotherapy. You can see that we improved the results, the leukemia-free survival of 20%, which was, of course, clinically significant. And this was because the relapse incidence with after stem cell transplantation was down from 80% to 40%. So this is an area where we can help the patients very much, and this was also significant in a multivariate analysis. Especially patients also younger, which have multi-aberrant clones and need a transplant, are the ideal or the typical indication for stem cell transplantation. You can see here one of the studies which we did in the Osho, in the East German study group. Here you can see that the patients were put into complete remission, and from these 37, only 22 went to a transplant or consolidation therapy. So most of the patients are dying because they don't, at that time, because they didn't have a bed, they didn't have a donor, they didn't have a fast allogeneic stem cell transplantation. And here you can see after 2002 study, which is now finished after 10 years, we had a very fast period from first complete remission to stem cell transplantation. And you can see here that only 2 patients actually died during the treatment. And here you can see the survival in these younger patients with high risk factors, high risk cytogenetics. You have 42%, you have only 7% of patients without a donor. So what we did not improve in these 20 years was the relapse incidence. And you can see that we are still on 28%, not even in Leipzig we improved this. We have now 4,000 patients, which we are just now evaluating, but there was no actually improvement in relapse incidence. So what is the cellular therapy today? It's treatment against cancer. We have done this with donor lymphocyte infusion, just by giving the cells of the donor again to the patient when he had a relapse. It's immune modulation. You will hear about this mesenchymal stem cells, which are used in different disciplines of medicine. We have randomized studies which are open. We have B-specific antibodies which are engaging cellular therapies, which is approved for ALL. And of course, the regenerative medicine is something which we have to define more in detail, the indications. Now, this is the paper which we wrote for donor lymphocyte infusion. That's the first publication for donor lymphocyte infusion, which was quite a surprise for everybody, because just by giving cells, we put patients into remission. So this is not working in every disease, but it's working in many diseases. And you will hear in the next 5 years, there are interesting protocols open where we are even infusing T cells to the patient without manipulation, where we possibly can modify the disease. What happened? Cellular therapy in Europe. You can see it here from this survey on cellular and engineered tissue therapies. You can see that we have here autologous and allogeneic cellular therapies outside of stem cell transplantation. You can see that we have cardiovascular, musculoskeletal indication, neurological indications, epithelial and autoimmune indications. And this is something which is also changing. This was from 2010 to 2015, from 2008 and 2012, published in 2010 and 2015. You can see that now we have 138 teams in Europe. We have 27 countries which are making cellular therapies, and we have more reports. In autologous, we have especially musculoskeletal and rheumatological disorders, cardiovascular 97%, are autos of this, and in hematology we have only 30%. So most of these are allogeneic, and but still we have in neurological disorders. You will hear today about very exciting results in neurological diseases, how cellular therapy can modify this. So we have not only hematopoietic stem cells, but also MSCs and chondrocytes, which are used for cellular therapy. And you can see from this publication, which we did some years ago, that even in breast cancer, cellular therapy has a place. You can see here a patient with multiple metastases in the liver after 28 days after stem cell transplantation. And we were able to define the minor histocompatibility antigens on the breast cancer cells, which were actually the reason why these metastases disappeared. One short word about the B-specific antibodies. Here we have antibodies which are looking at CD3 and at the CD19. So these short B-specific antibodies are able to join the cytotoxic cells with the tumor cells, and they can lead with the patient's own cellular killer cells to the apoptosis of the tumor. What is the future? The future, I think, is that we have to become better in cellular therapy, especially in solid tumors and also in hematological tumors. We are treating them with alloreactivity. So alloreactivity means it's not specific enough. And this is something which we just published in leukemia, where we just show that the price to have an anti-tumor effect is very high, and it's not specific enough. So we have to work on this. And this would be probably with tumor-infiltrating lymphocytes, with gene therapy, as we mentioned, with the CAR T cells. We will use this as immune modulation in mesenchymal stem cells much more than we are using today, and perhaps also better in regenerative medicine. So what is how we can be more specific? You can see here a reaction of the killer cells against the tumor. And you can see that we have different ideas here how we can make it better. Now, for the last 20 years, we tried to culture these cells. This was not very efficient because that was not in every patient we could culture these cells. We have here the way to stop some receptors which are actually modulating this reaction with anti-PD-1 and anti-CTLA4. We have the possibility to insert genes, as alluded before with the CAR T cells, which have here a specificity against an antigen which is on tumor cells. And we have also the possibility to insert genes. So this is not all. You will hear today much more exciting things which are going on in Amsterdam and with gene editing and so on. So this is something which is very interesting and which will be the future. Some short words about CARs. So CARs will be approved this year probably by the FDA. You can see that here stem cells are taken from the patients and they are inserted with a chimeric antigen receptor, and they are giving back to the patient. And here we have a lot of different protocols in leukemia, in ALL, in lymphomas, but also in colorectal cancer and breast cancer, prostate cancer, which will come up, hopefully, successfully. Now, for the mesenchymal stem cells, you can see here that we have myocardial revascularization, post-infarction, limb ischemia, diabetic foot will be one of the areas which are investigated, and immune modulation again in morbus Crohn, in lupus, in MS, and in graft versus host disease, but also in graft rejection process of the kidney. So 622 studies are registered today, and perhaps we can culture some of the, not organs, but at least some pieces of the body for those who need it. Now, what in this week will be implemented at the World Health Organization is that we propose to have 10 principles, and after they have elected the general manager in the World Health Organization on Wednesday, I hope they will approve these principles, where it's clear stated that governments have to ensure the ethical and effective procurement, distribution, and use of medicinal products of human origin. That means cells also. There should be equity in donations. There should be a proven efficacy of these treatments in the absence of alternative and affordable therapies. There should be, in the principle 4, there should be an informed consent from the donor and voluntary. There should be a guard against the exploitation of vulnerable individuals, and We should promote equity in donation. The donor should be protected against physical and psychosocial risks. The information should be routinely provided. Equity in access, this is very important. And this is not something which has to do only with money. I tell you, we were in Vietnam, and in Vietnam actually we were thinking, or even in Ethiopia, the government asked us there to help them to do this. And they have enough money there. They are providing more than 2 million per year just to make stem cell transplantation. To have an effective quality management system and vigilance, and also it's important that this process must be transparent and open to scrutiny. That means that we have to report all the patients and transplants. So one interesting way which I was excited, and we discussed this with the WHO, and actually Kaunas is here on the forefront of the new technology, is to make telemedicine. And you can see here how we did the last patients, or all the patients which have been transplanted here, and you will hear about from Thomas about more on this. So, what are the conclusions? The total of stem cell transplantations are increasing, allo more than auto, so we need allo centers. There is no plateau. Almost every patient has a fast available donor. Engraftment, reconstitution, speed, cost, and availability of beds issues are important even for alternative donor. The cellular therapies are emerging, mesenchymal stem cells, CAR T cells. We have an important role of scientific societies like the EBMT, like the WBMT, in telemedicine emerges as an important tool for the future. So thank you to all these people. Thank you to the Kaunas doctors. Thank you to everybody which made this possible.